Hello and welcome, dear friends. Today we are going to discuss about HIV and what makes AIDS a global threat. Before we begin, let us take a look at our objectives. The first objective is introduction to the AIDS, a brief introduction to pathophysiology of HIV virus, a brief explanation of the disease manifestation, an overlook at the recent progresses made in the treatment of the disease, and finally we will be looking at how this disease can be prevented and cured. The first we will be looking at the introduction. Acquired immunodeficiency syndrome or AIDS is a chronic, potentially life-threatening condition caused by human immunodeficiency virus or simply HIV. Human immunodeficiency virus HIV is a virus that attacks the human immune system and weakens its ability to fight infection and disease. Although the virus is mainly transmitted through sexual intercourse, it can also be passed down from mother to child during pregnancy, childbirth, and breastfeeding, or acquired via blood transfusion with infected blood, the shearing of needles like during drug use, or through needle stick injuries, if you are a healthcare worker, for example. HIV continues to be a major global public health issue, having claimed more than 35 million lives so far. In 2017 alone, 940,000 people died from HIV-related causes globally. There were approximately 36.9 million people living with HIV at the end of the 2017, with 1.8 million people becoming newly infected in 2017 across the globe. Now a brief history of the disease. Just over 3 decades ago, a new outbreak of opportunistic infections and capsuloid sarcoma was reported in a small number of homosexual men in California and New York. This universally fatal disease was eventually called the acquired immunodeficiency syndrome or AIDS, as it resulted in complete loss of CD4 positive T lymphocytes, which are the important components of the immune system. Within the first year of its description, the disease was also identified in hemophilics, injecting drug users, blood transfusion recipients, and infants born to affected mothers. Soon thereafter, a heterosexual epidemic of AIDS was revealed in Central Africa, preferentially affecting women. Little did we know at that time that these small number of cases would eventually mushroom into millions of affected individuals, becoming one of the greatest pandemic of modern times. Within 2 years of the initial reports of AIDS, a retrovirus later called the human immunodeficiency virus was identified as the cause of AIDS. Diagnostic tests were developed to protect the blood supply and to identify those infected individuals. Additional prevention measures were implemented, including risk-reducing programs, counseling and testing. Condom distribution and needle exchange programs were also introduced. However, HIV continued to spread, infecting 10 million individuals with the first decade of its recognition. The second decade of the AIDS was marked by further intensification of the epidemic in other areas of the world. The southern cone of Africa experienced an explosive HIV epidemic. Asia and the former Soviet Union or USSR also noted a marked increase in the spread of HIV. However, by the mid-90s, with the discovery of highly active antiretroviral therapies or ARTs, fatalities in the developed world started to decline. Use of antiretroviral drugs or ARVs during pregnancy also resulted in a significant decline in mother-to-child transmission of HIV in high-income countries. However, without access to ARVs, MTCT and mortality in low and middle-income countries continued to increase to 2.4 million deaths, with over 3 million new infections in 2001, with 2/3 occurring in sub-Saharan Africa. Now we will discuss something about the pathophysiology of the HIV/AIDS epidemic. HIV disease is caused by infection with HIV-1 or HIV-2, which are retroviruses in the Retroviridae family and lentivirus genus. After the HIV virus enters the body, there is a period of rapid viral replication leading to an abundance of the virus in the peripheral blood system. During primary infection, the level of HIV may reach several million virus particles per millimeter of blood. This response is accompanied by a marked drop in the number of circulating CD4 positive T cells, which we also called as T helper cells. This acute viremia is associated in virtually all people with the activation of CD8 positive T cells, which kill HIV infected cells, and subsequently with antibody production or seroconversion. The CD8 positive T cell response is thought to be important in controlling virus levels, which peak and then decline as the CD4 positive T cell counts rebound. A good CD8 positive T cell response has been linked to slower disease progression and a better prognosis, thought if does not eliminate the virus completely. During acute phase, HIV-induced cell lysis and killing of infected cells by cytotoxic T cells accounts for CD4 positive T cell depletion, although apoptosis may also be a factor. During the chronic phase, the consequences of generalized immune activation coupled with a gradual loss of the ability of the immune system to generate new T cells appears to account for the slow decline in CD4 positive T cell numbers. However, the symptoms of the immune deficiency characteristic of AIDS do not appear years after a person is infected. The bulk of the CD4 T cell loss occurs during the first weeks of infection, especially in the intestinal mucosa, which harbors the majority of the lymphocytes found in the body. The reason for the preferential loss of mucosal CD4 positive T cells is that a majority of mucosal CD4 positive T cells express the CCR5 co-receptor, whereas a small fraction of CD4 positive T cells in the bloodstream do express that receptor. HIV seeks out and destroys CCR5 expressing CD4 positive T cells during acute infection. A vigorous immune response eventually controls the infection and initiates the clinically latent phase of the infection. However, CD4 positive T cells in mucosal tissues remain depleted throughout the infection, although enough remain to initially ward off life-threatening infections. Continuous HI replication results in a state of generalized immune activation persisting throughout the chronic phase. Immune activation, which is reflected by the increased activation state of immune cells and release of pro-inflammatory cytokines, results from the activity of several HIV gene products and the immune response to ongoing HIV replication. Another cause is the breakdown of the immune surveillance system of the mucosal barrier caused by the depletion of mucosal CD4 positive T cells during the acute phase of the disease. This results in the systemic exposure of the immune system to microbial components of the gut's normal flora, which in healthy persons is kept in check by the mucosal immune system. The activation and proliferation of T cells that results from the immune activation provides fresh targets for HIV infection. However, direct killing by HIV alone cannot account for the observed depletion of CD4 positive T cells, since only 0.1 to 0.10% of the CD4 positive T cells in the blood are infected. A major cause of CD4 positive T cell loss appears to result from their heightened susceptibility to apoptosis when the immune system remains activated. Although new T cells are continuously produced by the thymus to replace the ones which are lost, the regenerative capacity of the thymus is slowly destroyed by direct infection of its thymocytes by HIV virus. Eventually, the minimal number of CD4 positive T cells necessary to maintain a sufficient immune response in the host is lost, leading to the disease AIDS, acquired immune deficiency syndrome. So CD4 positive T cell death and inflammation in HIV. Recent studies employed an ex vivo human lymphoid aggregate culture or HLAC system formed with fresh human tonsils or spleen tissues to model molecular and cellular events in human tissue during in vivo HIV infections. These studies found that 95% of the CD4 positive T cells die because of abortive HIV infection. These dying cells are resting and thus are non-permissive for productive HIV infection. So full viral replication was limited to the 5% of the activated CD4 positive T cells present in these tissues. These cells die by apoptosis. So abortive HIV infection occurs due to the slowing of reverse transcription promoting cytosolic DNA accumulation. So this viral DNA is censored by gamma interferon inducible protein 16 IFI16, which produces an innate immune response against the virus by activating caspase 1 in IFI16 inflammasomes and inducing pyroptosis, a highly inflammatory form of programmed cell death. These findings cast CD4 positive T cell death during HIV infection in a different light. Rather than the virus playing a major role, it is the host response to viral DNA produced during abortive infection that triggers the CD4 positive T cell death. Further, these findings identify novel drug targets that may be exploited to both block CD4 T cell demise and the chronic inflammatory response generated during pyroptosis. Now we will discuss the cells affected by the HIV virus. The HIV virus entering through whichever route acts primarily on the following cells: lymphoreticular system, CD4 positive T helper cells, the main target cell, macrophages, monocytes, certain endothelial cells, central nervous system, microglia of the nervous system, astrocytes, oligodendrocytes, and neurons indirectly by the action of cytokines and GP120. So what results in HIV pathogenesis? Following virus infection, a variety of intracellular mechanisms determine the relative expression of viral regulatory and accessory genes leading to productive or latent infection. With CD4 positive lymphocytes, HIV replication can cause syncytium formation and cell death. With other cells such as macrophages, persistent infection can occur, creating reservoirs for the virus in many cells and tissues. HIV strains are highly heterogeneous, and certain biological and serological properties determined by specific genetic sequences can be linked to pathogenic pathways and resistance to the immune response. Although the virus has cytopathic effects in productively infected cells, this effect may not directly contribute to HIV pathogenesis. Importantly, the virus can remain inactive, that is in the latent phase, in these productive infected cells for long periods of time. CD4 T cell depletion and chronic inflammation are the two signature events that drive HIV pathogenesis and progression to the AIDS. The CD4 positive GP120 interaction is also permissive to other viruses like cytomegalovirus, hepatitis virus, herpes simplex virus, etc. These viruses lead to further cell damage, that is cytopathy. Now we come to the diagnosis of the AIDS. HIV is most commonly diagnosed by testing the blood or saliva for antibodies to the virus. Unfortunately, it takes time for the body to develop these antibodies, usually up to 12 weeks. A quicker test check for HIV antigen, a protein produced by the virus immediately after infection, is preferred nowadays. It can confirm a diagnosis soon after infection and allow the person to take swifter steps to prevent the spread of the virus to the other cells. Now we come to the treatment of HIV infection. HIV treatment involves taking medicines that slow the progression of the virus in the body. Since HIV is a type of virus called a retrovirus, the drugs used to treat it are called antiretroviral drugs or ARVs. These drugs are always given in combination with other ARVs, and this combination therapy is called antiretroviral therapy or ART. Although a cure for HIV does not yet exist, ART can keep the patients healthy for many years to come and greatly reduce the transmission of this disease. Within 25 licensed antiretroviral drugs available for HIV treatment, there is wide choice of effective drugs for treating HIV individuals. With reductions in ARV price, availability of generic ARVs, and international financial aid, the number of people receiving ART has risen from just mere 2 lakh in 2001 to almost 8 million individuals in low and middle income countries. As a result of the marked increase in availability of antiretroviral therapies, the death rate in some of the hardest hit countries has started to decline following mortality reductions in the late 90s in the US and Europe. With the life expectancy of an HIV infected individual under treatment approaching an uninfected individual, there has been an increased emphasis on the starting ARV therapy much earlier in the course of the HIV infection. The revised 2012 DHHS guidelines recommend ART for all HIV infected individuals. These recommendations are based on evidence of ongoing HIV replication on disease progression. Additionally, because antiretroviral therapy use prevents transmission of HIV in discordant couples, the guidelines recommended that antiretroviral therapy or ART be offered to all HIV infected individuals to reduce the risk for their sexual partners. HIV and current challenge. In April 2000, the United States government declared HIV/AIDS a threat to American national security, marking the first time ever a disease has been entrusted to the National Security Council. Less than 3 months later, the United Nations Security Council affirmed Resolution 1308, which delineated the dangers that HIV/AIDS posed to the maintenance of international peace and security. So, acquired immunodeficiency syndrome or AIDS threatens to have catastrophic historical impact on the world, undermining decades of progress towards improved health and sustained economic development. Despite advances in the accessibility to ARVs, many challenges remain in the provision of HIV care. In the United States alone, the Center for Disease Control or CDC estimates that 1.2 million persons are living with HIV, of whom only 28% ultimately had suppressed viral levels. In one study in Mozambique, of 7,005 identified HIV-infected individuals, only half enrolled in care and only a small percent ultimately started ARVs and maintained adherence rates more than 90% for more than 180 days. This declining cascade in access to treatment is mostly due to an inconsistent pattern of diagnosis, linkage to care, differences in levels of CD4 cell count for initiation, and retention in care. In sub-Saharan Africa, the percentage of individuals being tested for HIV remains low. The average CD4 T cell count at the time of antiretroviral therapy initiation in low and middle income countries remains low, with a median cell count of 124 cells per millimeter of the blood. Intensified efforts are needed to identify those infected, initiate therapy, use standardized effective regimens, and encourage adherence and retention. Only with success at each stage in the continuum of care can the ultimate goals of improving health, extended lives, and preventing further HIV transmission be achieved. Let us discuss now the evolution of prevention strategies against HIV/AIDS. Reducing incidence has been a top priority for AIDS control. The initial prevention strategy was based on behavioral change like abstinence, being faithful, and use of a condom. But unfortunately, this strategy met with only limited success, except for Thailand's 100% condom campaign and Uganda's initial AIDS response. There is growing evidence that a relative decline of HIV incidence rates of over 25% between 2000 and 2010 in numerous African countries are the result of behavioral change. Condom use continues to increase, with several countries including South Africa, India, and Botswana reporting over 75% condom use during last high-risk sexual intercourses. However, condom use is still low in many other countries. A cause of concern is that in several African countries such as Uganda, South Africa, and Botswana, more men reported multiple partners in 2009 than 10 years ago. Access to sterile injection equipment and substitution therapy, referred to as harm reduction, is highly effective in reducing HIV spread among IDUs. Yet, several countries in Eastern Europe and Asia whose HIV epidemics are driven by injecting drug use continue to use ineffective punitive approach with sustained high HIV incidence as a consequence, also feeding the sexual spread of HIV. In addition, laws that drive MSM underground and prohibit harm reduction for IDUs can be major obstacles to effective HIV prevention. Such laws can be reversed was illustrated by India, which decriminalized same sexual relations in 2009. Biomedical advances in prevention of the control of this HIV disease. Some of the measures are use of antiretroviral therapies or PrEPs. Use of ARVs prior to sex is referred to as pre-exposure prophylaxis. Precoital use of 1% tenofovir gel reduced HIV acquisition by 39% in women, and daily oral tenofovir emtricitabine among MSM reduced HIV acquisition by 44%, with greater efficacy observed among individuals who achieved high levels of adherence in both trials. Daily tenofovir and tenofovir emtricitabine reduced HIV acquisition by 66% and 73% respectively among uninfected partners in HIV serodiscordant partnerships and in young heterosexuals in Botswana. While these studies are encouraging, two studies produced conflicting results, finding no efficacy with either oral or gel tenofovir. The explanation for these discrepant studies may be due to low adherence to the drug regimens or differences in mucosal penetration. Recently, the FDA, that is the Food and Drug Administration of America, approved daily oral Truvada for pre-exposure patients in combination with safer sex practices to reduce the risk of sexually acquired HIV infection in adults at high risk. Treatment as prevention. Viral load is the single greatest risk factor for all transmission modes, and treatment as prevention is based on the fact that antiretroviral therapy can reduce plasma and genital HIV viral loads to undetectable levels, thereby reducing reinfections. This principle was first proved for prevention of MTCT and subsequently in preventing sexual transmission by 96% within couples. This shift from a focus on downstream therapeutic application of ART to a more upstream preventive benefit of eliminating HIV transmission has inspired optimism for the creation of an AIDS-free generation. Then the combination therapy or combination prevention. There is consensus that no single intervention of medicines or drugs or antiretroviral therapies can stop the spread of HIV/AIDS, and that combination prevention is the best approach. Effective biomedical interventions coupled with behavioral and structural approach. Effective biomedical interventions coupled with behavioral and structural approach may now successfully reduce HIV incidence to very low levels and ultimately control the epidemics of HIV/AIDS. There is also a need to test in community randomized trials how effective treatment as prevention workers at the population level, what the optimum program design would be, and in combination with which prevention interventions, and equally important to ensure good treatment coverage for those in immediate need of the clinical treatment. From both an impact and a cost-effective perspective, HIV prevention efforts should focus more on populations at highest risk for transmission and should be customized to a wider range of realities than is presently the case. It should be stressed that all components of combination prevention require some form of behavioral intervention, be it to ensure adherence to condom use or ARV-based prevention, or to prevent increased risk of behavior. However, even when optimally applying the most effective HIV interventions, most mathematical models suggest that by 2031, 50 years after the discovery of the AIDS initially in 1980s, there may still be as many as 1 million new infections annually throughout the globe. While desperately needed, the search for a vaccine still eludes investigators although one recent trial in Thailand with a 31% efficacy provided a much needed boost to vaccine research. The challenge ahead: after 30 years in the AIDS epidemic, there are over 34 million people living with HIV and still 2.5 million new infections and 1.7 million deaths each year, emphasizing that the global response will have to be sustained for at least several decades. There is now an impressive array of evidence-based interventions that can be implemented to treat established infections and prevent new ones. Studies among high-risk populations have shown that HIV prevention can work even in the most challenging settings. Yet, despite this, United Nations AIDS reports said that only 60% of sex workers, 46% of IDUs, and 40% of MSMs were reached with HIV prevention programs in 2008. And HIV incidence is rising again in several populations, including in Uganda. In 2011, less than 25% of all HIV infected individuals had access to or were biologically suppressed with antiretroviral therapy treatments. To ensure ARTSS, many lower income countries are still dependent almost entirely on the international aid, which has declined in recent years. As we witness the increase in chronic care and chronic disease in people with HIV as a result of treatment and increased life expectancy, innovative solutions of care delivery must be developed, including task shifting and integrated service delivery in the communities. Dear friends, this was all about today's lecture. Hope you have understood it well. We shall meet again with a new topic. Till then, take care of your good self. Thank you.